Good morning. My name is Justin Neese. I'm the Chief Growth Officer for Medi Analytics. We are an advanced data analytics company focused on financial outcomes for payers, providers, and employers. Welcome to today's panel discussion on patient rights policy versus patient access reality. We've already heard some things on this previously. For more than 2 decades, policymakers, advocates, and innovators have advanced a clear principle. Patients should have the right to access and control their own health data. From HIPAA's right of access to the 21st Century Cures Act to CMS's interoperability and patient access rule, each wave of regulation has strengthened that promise, and most recently, frameworks like TEFCA's individual access services aim to make patient data exchange seamless and secure across the nation. But, as we know, in practice, there remains still some challenges. Patients, especially those managing complex or chronic conditions, still encounter a fragmented ecosystem. Portals that don't quite connect, APIs that aren't yet interoperable, processes that require persistence rather than empowerment. While policy recognizes that patient rights, practice often tests the patient's resilience. So today, we're bringing together a spirited and deeply experienced panel of voices who live and breathe this work every day to ask a few critical questions and answer those. How close are we to realizing the vision of true individual access under TEFCA? What does real patient empowerment look like in the daily life beyond compliance? And what best practices and processes can finally close the gap between policy and reality? So it's my pleasure now to turn it over to Anna, I think, on the team. Thank you.
Hello, everybody. It's a pleasure to be here once again. How many of you were here last year? Yes. Well, I'm sure you all took notes and remember everything I said, but I wanted to start by saying, for those of you who may remember, we spend a lot of time, particularly as patient advocates, pointing out all of the things that don't work. But what you might remember, last year I presented a case of information blocking. I was in the midst of a very significant issue with my eyes. I was in the process of losing my vision in my right eye. And I would like to report that this time last year, my vision in my left eye was 20/300. My vision in my right eye was 20/600. As of last week, my vision in my left eye was 20/20, and my vision in my right eye was 20/70. So there are things that are working, and that also means that I'll be able to see all of you if you're multitasking and on your computers and emails. So anyway, keep that in mind. So having said that, I'd give you a little bit of a background for those of you who didn't take notes. I am here, I work as an independent consultant. I'm on the board of Sequoia, a member of the Health IT Advisory Committee. I've done a whole bunch of nerdy things over the years in healthcare, but most of that is primarily motivated by the fact that I have type 1 diabetes, a very complex patient. I have all the complications from diabetes. I take 29 meds currently, use 11 devices, have 17 doctors, and 7 patient portals. And very little of those devices and data and portals are in any way connected. Still, I've been advocating on these issues as a patient who was frustrated, started my first health IT company 14 years ago, I believe, as a frustrated patient, began to realize that a lot of the data dysfunction I live with is fixable, but nobody bothered to fix it, and started speaking up about it in different public policy forums. We are still here today with a little bit of progress along the way, but from an experiential perspective, patients are still facing a remarkable amount of hurdles getting access to their data. So I've been leading the effort with Sequoia, with the consumer engagement work group. We'll talk a little bit about that. But before we get going with the panel, I'd like to ask my panelists to introduce themselves and talk a little bit about what they're doing in their day job and in the work they're doing with Sequoia to empower patients.
Yeah. So first thing I'm going to say is I need to update my biopic because I'm completely like gray in the beard now, and I could blame that on all the work that we have to do within this industry. We all understand, but I also have 4 kids, and I think the 4 kids led to the gray more than the work. The second is so I am with Oracle Health. I do regulatory strategy. So I feel a bit like the odd duck up here because I'm more on the regulatory compliance focus of things. And I'm sitting up here with a lot of very good patient advocates. I'm on the consumer engagement work group, and I sit in, and the work that Anna and everyone does is just fantastic. But my primary role is regulatory strategy and compliance. I try and understand what the regulations are and how they impact our product and how they impact how our clients use our products so that we can ensure that they're ready to meet their needs.
Cathriona?
Good morning, everybody. My name is Cathriona Dolphin-Dempsey, and I'm the Director of Regulatory Informatics at Stanford. I've been immersed in the world of regulatory for the last 12 plus years. So I've come through all of the interviews at different stages, and now the promoting interoperability, and I also work in the information blocking project at Stanford Healthcare. I am a co-chair with Anna and Brian Van Wyk for this group. So I'm delighted to be here, and thank you to the Sequoia for inviting me back to be a panelist.
Hi, everyone. I'm Deven McGraw. I'm the Chief Regulatory Officer and Privacy Officer at Citizen Health, which is a platform that helps patients to gather all their health information from all the places that they've been seen so that they don't have to undergo the burden that patients often feel or their caregivers feel when they're trying to amass records and collect them all in one place so that they can use them for self-care, for self-management, to help inform a caregiver about what's going on with their health, or to contribute that data to research if they choose to do so. We have a lot of rare disease patients on our platform, and research is actually a really high priority for them because for many of them, there are not treatments necessarily. And so they're very eager to push their data into spaces where they can advance the development and use of therapies for their conditions. So yeah, I'm really happy to be here. I want to also thank the sponsor of this panel and also to thank the Sequoia Project for always keeping this topic top of mind and a big priority.
So to give you a little bit, thank you, everybody. To give you a little bit of an overview of what we're talking about, what we're doing. I've been leading the work of the Consumer Engagement Strategy Work Group for the past year and a half for Sequoia, co-chairing with Cathriona and Brian Van Wyk who works with Epic. And it's an incredible group of folks, a lot of really passionate patient data advocates, members of the health information management world, EHR data vendors, providers from places like Stanford and others, all of whom are passionate about improving lives for patients. And we began this work based upon a body of work done by a prior work group called the Consumer Voices Work Group, which really spent about a year of doing a big focus group with about 7 different patients, documenting the different types of burdens and struggles that many patients live with. And these are, when I first read the report, I wasn't involved with it. When I first read it, it was like, yes, this is the stuff that we've been saying for many, many years. This is what we all live with. How do we start to fix it? So when we launched the work group, I really wanted to get into what are the issues that we're experiencing. We have come an incredibly long way with health technology policy. We have come a very, very long way with health technology. I mean, we've moved beyond HIPAA and some of the earlier fights that we had around this issue. We've got the information blocking rule. The The technology is there. As taxpayers, we've spent, what, $40 billion investing in this infrastructure. But why is it still difficult? And we spent a lot of time really digging into the specifics of that, and looking at it, saying, you know, from a work group perspective, other folks are working on interoperability, and that is complex. But what are the other kinds of things that are outside of that? And a lot of what we realized is that despite the fact that technology is there, the policy is there, there are a lot of operational and procedural issues that just get in the way and make things very difficult for patients. And most of these things are incredibly fixable. It's just nobody's bothered to fix them. And nobody has bothered to think through many of these tasks from the perspective of user experience. So that's much of what we've been doing over the past several months, is putting together best practices around that. But before we get into those specific best practices, I'd like to go to each of the panelists and say, all right, here we are, it's 2025. Info blocking's been out since what, 2021, 2020?
2020.
We now have ASCP saying we're going to actually enforce this rule and put some muscle behind it, which is incredibly refreshing. So, Josh, I'll go to you first. Why is it still so difficult for me to be able to get access to my data? Why did none of my 7 portals actually connect? And why do I still have, you know, medical records teams at my ophthalmologist who'd never heard of things like the information blocking rule?
Yeah, and if I could provide a succinct answer to that, I don't think any of us would probably be here, because that is, you know, the big challenge. And one of the things I don't have my phone out to check my email. I'm trying to go through and make sure I hit on a few points here. So one of the things that we wanted to hit on with this panel is information blocking compliance, because Dr. Tom Keene just spoke and talked to the enforcement and some of the activities that are happening. And one of the things that I wanted to touch on is just thoughts in general around information blocking compliance, which is, in my mind, and this might be because I'm from the regulatory compliance perspective, but information blocking, in my mind, is a lot like the counterbalance to some of the protections. So HIPAA has a lot of great protections. It also is designed to allow patients to get their information and flow their information from place to place. But what happens in a lot of cases is you have maybe overprotection, right? Like you kind of counterbalance too much to one side because you want to ensure that you don't have breaches. And information blocking, to some extent, is designed to try and come in and maybe force you to reevaluate some of those decisions and some of those conversations, and really kind of evaluate, is this the best way to ensure that we're providing access while also protecting the information? One of the other things that I wanted to talk about is that enforcement is necessary, right? And Dr. Keene spoke to that. So without enforcement, you know, it's kind of an empty requirement. And so I think we've all been waiting to see how that plays out. And in the meantime, what we've seen is that a lot of states have started to step into the ether and started to evaluate the roles that they might play. So we've seen new laws that have been passed that have impacted information blocking compliance. And we've seen several court cases that have come out that have impacted information blocking compliance. And this is where I wanted to do a quick shout out to the information sharing work group and the collateral that has been done from the information sharing work group. I see Sam over here. Sam was a big part of that. He was a co-chair of one of the work groups, and Mel Solis, she's in here somewhere, I imagine, was also a big part of that effort, along with quite a few others who helped put together this collateral. We just released it last week. And what we're doing on the information sharing work group is we're trying to outline not only some of the state activities so that they can be incorporated into the compliance considerations, but just in general, how those compliance considerations can be worked into the everyday activities of these organizations, right? Because information blocking at this point really should start becoming part of your everyday activities Shout out to Dr. Eisenberg, who's been saying that for several years. Um, so those are the things that, a couple of things that I wanted to hit on with the information sharing work group, and I'll just mention real quick, I don't want to take too much time, but just a shout out to the Sequoia project, Interoperability Matters, and all the work groups that they do, not just the information sharing, the consumer engagement work group, the data usability work group with Didi, the pharmacy work group, the payer-to-payer work group. Like, there are all sorts of activities that are happening. And I think that all of these are key efforts. And this kind of gets back to the question that you asked, is why is this still a challenge? And I think that in a lot of ways, we all see some of the same problems, but how we approach those problems, the foundation that we're starting from, it's all a little different. And having those industry groups come together and be able to talk and address some of those problems collectively, I think is a key to trying to solve some of those. From the health IT developer perspective, because that's kind of why I'm up here to present the health IT developer perspective, is there's a lot of data, right? Like, there is so much data that could impact every single patient and their unique case, right? Like, the unique factors that play into what is the resulting diagnosis for each individual patient could wildly differ from patient to patient, and understanding what information you need and when you need it is a key challenge, and also trying to understand that you have the correct patient information. And I think that, as an EHR developer, we are trying to ensure that we are interoperable. You just saw that we became designated QHIN. We've been working in several areas to try and be as interoperable as we can. But there's a lot of activity in the background in order to do that, right? Like, there's a lot of standardization work. There's a lot of work group activity that goes into understanding that when I say this is my piece of data, that it's the same as your piece of data, and that we're sharing the same information. And all of that foundational work really has to be done before we start truly exchanging information. And I think the health IT, the EHRs are kind of at the center of a lot of that work, and understanding the amount of data, right? Like, EHRs do not hold all of the data that is necessary. Typically, we don't store it all. So being able to access all that information, determine if it needs to be stored, the best way to share that information, in a lot of ways, having the patient as the advocate and the patient owning a lot of their medical record is one of the best things that could happen, because the patient truly has the ability to get all of their information in one place, whereas an EHR is more of a specific clinical record to that.
Theoretically, the
Right,
patient.
theoretically, right,
Yeah.
theoretically, yes. And so I think we'd all like to see that, but there are a lot of challenges in trying to determine what data is needed, when it's needed, how to present it, how to share it. Those are all individual challenges that need foundational work and work in the background. And I think the industry is doing that work, but it just takes time.
Yeah, and I appreciate that, and I certainly understand that it's complex, but like, time really adds up. I mean, we've been doing this for quite some time.
Yes.
And I'll skip Cathriona for a second and go to Deven, on the heels of that comment, because Deven and I think we first sort of interacted. I remember you were in the Health IT Policy Committee. You asked me so you'd heard me speak or something, and you asked me to speak at one of the meetings. I remember my presentation. It was called "Water, Water Everywhere, Not a Drop to Drink." And we are still in that situation. Data is everywhere. A lot of people have a lot of my data. I still can't get it. How many panels since then have we done on this very topic? And we've worked on this issue together for many years now. So why is this still a thing?
Why is this still a thing? Yeah, I mean, I think Josh started to outline some of the complexities, and that can take time. I think patients are not really patient, and they shouldn't have to be, when the law's frankly been quite clear for many years. Patients have a right to this data. We have improved the way patients get it. Through patient portals, things have gotten easier. Through TEFCA, things hopefully soon will get easier. There's still not enough data flowing. We're spending a lot of time like trying to figure out how to basically remove all the yeah, but what abouts from all of that conversation. But when we get data for our patients, even with those pathways, we still often need to rely on what I'm now going to call the Amy and Morgan Gleason method, which means going to health information management departments and getting the data that we need, because oftentimes it's a lot more, and certainly what the patient has a right to under as a designated record set is a lot more than exists in a certified EMR or might be made available through TEFCA or Care Equality or a health information network that is operated within a state or a region. It's the old-fashioned method. It's also often there are historic paper records. We have a lot of pediatric patients on whose parents use our service, and some of those records are a lot older than our efforts to digitize them. And there are folks here in this audience who actually know really well. They're the release of information vendors who frankly are a little bit of the last mile in patient access. They have a lot of experience at releasing data to patients and services like ours that are, and it's not that complicated for them to do this. We kind of need to port those models of ease, but with, trust but verify kinds of approaches into the space where things get a little bit easier, because we still do from time to time hit obstacles like we're right now trying to get a pediatric neurologist in California to reduce an invoice that she's provided to the patient for copies of her child's records of $264 for one and $500 for another, reliant on old advice or outdated or incorrect advice from the California Medical Board that says that she's allowed to charge 25 cents a page, not putting in there at all that HIPAA actually says it's labor costs associated with making the copy. And there's no ream of paper that I have ever bought that cost me 25 cents a page to get it. And it's actually the HIPAA violation, because these are partly paper records, so information blocking is maybe not, but the invoice itself has the violation literally in it. It says, "Ooh, spent 2 hours making the copy. That's a labor cost. We will pay for that on behalf of the patient. We pay all HIPAA compliant costs." And 25 cents, and on top of that, 25 cents a page for the copies. Hence, $264, $500, nearly $1,000. What patient can afford that? No patient can afford that. That's not how we should be operating. And it's not to, look, patients get free access by law when they connect to a portal. They should get free access as well through TEFCA. I believe that's part of information blocking if it's an internet-based method. But we will always need, patients will always need more data likely than is present in these systems, either because it's historic or because it's the type of data that isn't customarily shared through these vehicles. These folks are needed, and it still gives you this incomplete picture. And it's one of the reasons why the work Anna and Katrin that you all did and Brian led all of us to do around, what's the practical experience of a patient? Because really there's sort of multiple pathways. And for any particular data holding institution, they've really got to consider, how can I help get the patient their data in the most expeditious way, in the way that works for them, and that takes into account all of these various pieces? Because it all needs to be knit together to give the patient the complete package of their records versus a little bit here and a little bit here and a little bit there.
Cathriona, you work for Stanford Healthcare, really big hospital system. At Stanford, they know a little bit about technology. So I'm sure Stanford's probably a bit more advanced than some of the stuff in, like my ophthalmologist office last year. But from your perspective, as somebody who works from the provider industry, why is this still so difficult? And more specifically, if you could talk a little bit about, you were instrumental in reviewing, as a work group, we did an audit. We were trying to figure out what are the things that, why is this so difficult? And we just simply divided up and conquered across the different work group members and asked people to start exploring this issue at different hospital centers and different providers? And how difficult is it to get access to your data? What are the practical steps that you have to go through, et cetera? If you could talk a little bit about that, as well as, you know, your more broadly speaking, your perspective as working as a provider.
Yep, absolutely. So so my background is regulatory, as I mentioned earlier on, and as part of that regulatory requirement, through all the meaningful use stages, is that there is one objective in there, which is provider exchange of patients. And there's a measure in there that is you must provide your patient with electronic access to their information. That's where the world started for us with regards to meaningful use. Going forward from there, then, in regards, and that's where we started at Stanford and every other organization to meet the requirements, because if you didn't, you know, there's a penalization towards it now. When we started with this group, and as you mentioned, we did a survey, and we surveyed 23 organizations, just random survey of organizations across the country. And we were given very clear points of what to look for within the organizations. And the results were just, it was outrageous. There was, where do you know, what search engine do you look at? Where do you look at for different information in regards to, you know, what should be shared with the patient? Where can you possibly get access? What organization or department within the organization actually can share that information with you, and what format? And from that, we've clearly identified that there is a huge gap in the organizations as to what is shared. So that's where we come back as a group and we pulled together what our tactical plan was going to be. And that was going to be is that we wanted to create best practices. We wanted to create a toolkit. We wanted to create a pledge from organizations. And we also wanted to submit a proposal to the Center of Medical Services, CMS, to consider with a kind of a proposal, I guess, is what we submitted to them in what we feel would be predominantly help across all the sectors. And for that perspective, I'm going to pull it back now to regulatory, is that we submitted our proposal for our physician fee schedule, which is due, came out, the final version came out last week. But it was that all of the toolkit that we created, which encompasses what information blocking was and what the requirement was, and that would be added into the measure, the objective of provider to patient exchange, an attestation measure. And in there, every organization would create a resource hub where specifically for the patient, so that the patient can go to this hub in the organizational page, and in that hub would be all of access to your portal, as well as access to what each state should charge you, what format you should be able to receive your information. Unfortunately, it wasn't added as a final rule to the physician fee scheduling. I'm hoping that we will submit it again for the IPPS. But I think we've done all the groundwork, and I know it's been mentioned here earlier today that regulatory takes time. Our group has done all of the groundwork. We have worked really hard to get together what the best practices and this toolkit that can be shared from a one provider office all the way up to Stanford Healthcare even. And it is how, with the checklist as to how exactly to implement everything. So we've done all the groundwork, and we're just hoping that that CMS will add this into a final rule, both for the inpatient provider patient system, which is the IPPS, which is the hospital, and also the under the physician fee schedule. So that is what I'm hoping that we will get from all of the work that we have done as a group. And I hope that answers most of the questions that you asked, Anna.
You've covered a lot. And just to emphasize and sort of pick up on some of the points that Cathriona covered, in the audit that we did, and some of we did a whole series of work group meetings, really exploring what are the barriers to individual access. And, you know, Mickey Tripathi did a 90-minute masterclass on all things individual access. We, you know, that we had lots of different subject matter experts come in and speak to us about the issues. And then we did this audit. And from when I took a step back and looked at it, what we'd heard and seen and explored and seen with our audit and what my experience is as a patient is I realized that everything about patient data access, patient information, information about, your local exchange, HIPAA, preferences, consent, all of it is arranged in very different spots on the provider website. And the way that it's arranged tends to reflect the structure of the hospital or the structure of the regulations that required that particular bit of information to be on the website. In essence, like all of these things were up there because somebody had required them to be up there. So they were organized in different spots because different parts of the provider system had responsibility over it. And nobody took a step back and said, if I'm a patient who's really stressed out, like I was this time last year, as my mother was dying, I'm losing my vision, I'm totally panicked, sitting in a health IT advisory committee, trying to figure out how in the world do I get this provider to give me the data and the images that I need so that I can keep my vision? How does a patient in that frame of mind, even somebody as informed as me, begin to start figuring this stuff out if it's like an Easter egg hunt through the hospital website to get everything that you need? It's very challenging, but it's also super easy to fix if people want to fix it. This doesn't require regulation. It requires a user experience designer. And most hospitals and systems have that on staff already. We have to come together and get providers and all of the health information management vendors and EHR vendors to really think through from the perspective of, not complying with the law, but serving the patients that you're choosing to serve or that you're seeking to serve, and really thinking about what is their experience. These people don't think about data every day, all the time. Some of us over time are forced to, but for the most part, they don't. And when they're experiencing this and trying to confront this for the first time, they experience this sort of labyrinth of information in all these different places using terminology that nobody really understands until we can Google it all now or do Chat GPT to figure some of the stuff out. But why do you want to do that when you're stressed and all you really want is your data? And again, this is at a time when we can, at the same time, on our iPhone, manage and readjust our 401k, manage our checking account, order a pizza, and stream Netflix, all simultaneously. And when I'm trying to get access to my images, I'm told I have to mail in a paper check, send it to some place in Gaithersburg that I've heard of on the traffic reports, but never been. After it gets there, it clears, the check clears, they have 30 days to get me in the mail the records that I need for a doctor's appointment in 4 days that their doctor had told me was an urgent doctor's appointment to save my vision. So why is that the thing? And this is a very fixable thing. We just have to find ways to incentivize the industry to fix it and to identify, to call the issue what it is. It's like, this isn't a technology issue. This isn't a policy issue. This is a failure to consider the complexity from the perspective of the patients that these providers and organizations are seeking to serve. So that is what our best practices are really outlining. As Cathriona mentioned, we have a series of best practices. We've developed a toolkit to support the implementation of those best practices. And we're working on a way to incentivize. We're thinking about a pledge. Pledges are kind of hip and cool these days. I hear CMS has one. But we're leaning more towards like a designation for Patient Data Access Center of Excellence. But as a work group, we're still working through the specific stuff, and I love all your comments. But that's the direction we're going, and that's some of the stuff that Cathriona was talking about. So that's what we're doing as a work group. Beyond that, what are the things that and I'll go to you first, Josh. what are the things that need to happen, or what can we do as an industry and the people in this room to really create this sense of urgency to really make this stuff work and make it to fix it so that Devin and I still aren't doing panels 10 years from now on why patients can't get access to their data.
I want to retire.
Um, you know, I'm not sure the best way to create a sense of urgency. I think what you just outlined is a great step in that direction. Like uh, the way that you were talking through it, not only the Center of Excellence or the designation that you all are working on, and I've been part of the work group and listened in as you all have really advanced this in a lot of different areas and kind of taken the entire ocean and tried to boil it and done a really good job of it. Um, so I do think that a lot of it probably comes down to stepping back and trying to reevaluate and approach this from a different perspective, right? I think a lot of times we do end up in our own perspectives, right? Like we all have our day jobs that we focus on and we're trying to get through what we're required to do. And we don't always step back and look at it from the patient perspective, even though we're all patients and even though we all have family or friends that have gone through experiences, right? Like, I think that a lot of it does come down to trying to take a step back and uh, to look at that journey and what that is, and the roles that each of us could play in trying to lessen that burden and just keep lessening that burden. I don't think it's like a, here's your checklist and you're all done. It's a constant reevaluation of we have new technology, we're going to reevaluate how we can potentially make this a better process. And each time, this is perhaps an annual process or something where you're looking at this and reevaluating and trying to reanalyze and make sure that you're still trying to make this as simple as possible. And that would be my thought.
Katrina, and you work in a really large hospital system that is very advanced in many respects, but still isn't doing this the way, I mean, there are still issues in terms of like putting all of this stuff in a way that makes sense and would conform with the best practices that we've outlined, which we'll be sharing a draft of for people to comment on soon. What do you think it will take to get a sense of urgency? And you don't have to talk about Stanford necessarily, but talk about within these large provider systems. What is it going to take to get a sense of urgency to really focus on these issues? Repeatedly, I'm told when talking to this about with different people from the provider world that nobody's going to do this unless they're forced to do it. And I'm with Amy in the sense that I would prefer to not have a regulatory approach. I think that is not the best way. It's a very blunt approach. It's cumbersome, and we want to get this done before 2030. So it's much better to have the industry do it themselves and have a private sector initiative. But if the providers are telling me that that's not going to happen unless the government forces them to do it, how do we get that sense of urgency inserted into the minds of people, these large provider systems, to actually embrace something like this?
I mean, I'll go back to regulatory. I know you're not a lover of it, Anna, but I think if there's a regulatory requirement that you must share and what you should share within that patient portal and in your organization, like with the toolkit that we've created, I think if you don't meet the requirements, then it's a 9% penalty for as part of the IPPS and the PFS final rule. If you don't meet the requirements in the event of an audit, you have 9% of a penalty on all your CMS payments. I think that's going to hit the pocket of a lot of organizations across. So that's where my approach is, to push for regulatory and to have it included in those two programs that at least I work under. I think also sharing the stories. We've heard many stories. We've heard your story. We've heard many stories from our work group as well as And I think sharing those stories with people, because we often say a picture tells 1,000 words. Well, I also think a story tells 100,000 words, because we heard from Amy today as well, the story of her daughter. And I think if we can share those stories with groups, I think we need to leverage, at Stanford, we have a patient experience team, and they meet with our patient family advisory councils. From that group, we find they identify what's working within our portal, what's not working within our portal. And then those teams work with our My Health team, which is our MyChart team at Stanford. And that's what makes our group, I guess, our portal access is at 1.7 million unique users. You know, we monitor that on a monthly basis of the portal usage, and it's broken down into even the departments and what they're doing at the department level. But again, and that is brought up to leadership. So we need our leadership, our executive leadership, we need our clinical leadership, we need our patient experience, our frontline staff to be pushing and educating our patients into what is available to them in across the board. I think that's where we will kind of get that final push. I also think there is, is there a possibility of a little bit of a sense of competition? We're talking about our pledge that we're looking at potentially, incorporating. We've created a subgroup so that to work specifically on this. But how cool it would be if we had a certificate that shows that, for example, Sutter Healthcare has our patient access a certificate on their organization page, that they are sharing all of their information. They're a gold standard for sharing their information with their patients, and if a new patient comes to the Bay Area and they see the Sutter they have a gold standard at this. The other organizations, like we'll say my own Stanford or Kaiser, don't have it, for example. There's a sense of urgency from a marketing perspective. I want to go to the organization that is sharing my information and that I can access when I want to access and share it as I want to share it. So I think there's a few angles that can be kind of ironed out and pushed forward. But again, I'm looking for CMS for regulatory push. Sorry.
And Deven, thoughts? And one of my many favorite things about Deven's company, Citizen Health, they do incredible stuff. But when they first got started, they hired a bunch of former bill collectors to go after the health information records.
Yeah.
And I love the anecdote. It's like, that's the kind of person you need to hire to be able to get this information. So how do we get beyond that, Deven?
Bill collectors? No, we do actually, and we had to let a couple of them go because they were super aggressive, which doesn't come over well when you're trying to get cooperation. But for the most part, look, I think we're on the right pathway, and I actually think this toolkit and ways of highlighting organizations and institutions that are doing it really well helps. Some of you may remember in the early Citizen days when we still had 2 I's after RC, we had a scorecard that we put up. And it was mostly about wanting to reward entities that were doing a really good job at responding to our requests. That's the only way that I had data on how requests were honored. But I would love to brainstorm a way to elevate the people who are doing it well to the top of the list, so that they're getting credit for all the hard work that they're doing to make things easier, to make it so that the patient has a seamless experience and understand. You can get this information from your portal if you'd like. You can get this information from our health information management department that's not in your portal. And here's how you do it in a single sort of entry place and a way to be able to escalate your requests if you have an emergent situation like you did, Anna. Not all of those situations are emergent, but when it is emergent, you want to be able to pull on that thread and get it. So I think we're really on the cusp of something that could really make a difference in terms of elevating, publicly reporting on performance in a way that actually changes things.
Thank you. And I mean, when we will be releasing our best practices and our toolkit in draft form in the coming month, maybe at this point, we'll probably do it in early January, since that's after the holidays. I would really love to get the input of everybody in this group. It's meant to be a draft. We want your thoughts. We want this to be a document that can really work for the industry and inspire industry excellence. I would love to find a way to to incentivize and to motivate the industry without having to go to Amy at CMS and saying, find these people, or take away some of their reimbursement money from CMS. I maybe I'm a Pollyanna about some of these things still in some respects, but I really feel like individuals can make choices to do the right thing and to push for the right thing in their organization. It's just we need to give people the ability to do that and to tell them what is the true north to push towards, and that's what we're hoping to do with the best practices. But I want to say thank you all very much for listening. Not that many people are multitasking because I was watching, but I really want to say thank you so much to the panel. Everybody has been wonderful. All of you are on the work group that I'm leading and co-chairing, and I really appreciate the incredible amount of effort you've put into it. And thank you.
Thank you all so much. That was awesome. I love then when we identify a problem and come up with a solution. Just makes me happy. So we're going to take a brief break, sponsored by Smile Digital Health. Please return at 11 for a session with Dr. Eisenberg and Dr. Blair to talk about putting the trust in trusted exchange. I think we all know that trust is hard earned and easily lost. So back at 11. Thank you all.